Okay, now we are ready to begin. Okay, thank you everyone for being here on this fine Tuesday. We are always thrilled to bring another California Telehealth Resource Center webinar to you all. Today we have a very important session, part one of a digital health update, RPM and RTM and more in the Medicare physician fee schedule. As always, with our webinars, we like to provide a little disclaimer that CTRC does not provide legal advice. We are here for educational and informational purposes only. If any commercial products or services are mentioned in today's session, please know we have no relevant financial interest or arrangement. CTRC is wonderfully supported by the HRSA and the California State Office of Rural Health, and you can find our grant information there at the bottom. A few other reminders before we get started. Attendees' cameras are off for this session. We are in a webinar, but that does not mean we don't want to hear from you. We would like you to very much use the chat and Q&A features to interact with us and our presenter today. So please, throughout the session, use the chat to post your questions and comments. As a last reminder, we will also let you know that today's session is being recorded, and the recording will be made available on CTRC's YouTube and website. So if you'd like to revisit any of the content or share with your colleagues, please do. That we'll introduce today.
Great. Thank you, Aislinn. Aislinn is our manager of the California Telehealth Resource Center. My name is Sylvia Trujillo. I'm the executive director. We're really pleased to have you all attend. We're pursuing a slightly different format. We are covering today really what we would call the remote management digital health services. You'll see outlined here on the left the specific topics. I'm going to provide a little bit of a baseline intro for some existing codes so that you can have some context for the deep dive that Jarrin, our guest speaker and expert, is going to go into. We want to flag that all the telehealth updates, that's the interactive audio, video, audio only services and the changes that are upcoming on that front, we will be doing in a follow-up webinar that is also 30 minutes. Let's go ahead and move to the next slide. So I'm going to take a brief moment before I introduce our expert, Robert Jarrin, so that you all are basically starting in the same place, so that you have a clear framework of what Jarrin's going to be talking about in the context of remote management services. So there are basically two very broad buckets of remote management services. The first on the left is remote physiological monitoring. And this is really straightforward. There are basically four codes that you use for remote physiological monitoring. And physiological monitoring is typically used for things like tracking, just like it sounds, physiological indicators, whether you're looking at blood pressure, you're looking at blood sugar levels, you're looking at weight. Those are physiological responses. And whether you're using it for diabetes or you're monitoring cardiovascular disease, these are going to be the codes that you use. There is a code for the setup of the device and education of the patient. Then there's the professional services of the individual who's actually evaluating the results that are being transmitted the first 20 minutes. You can bill that. The subsequent 20 additional minutes has another code. And then the device supply code. So that's the actual device that's collecting and transmitting the information. So for remote physiological monitoring, there's one device supply code. So we call this generally a lumper. On the therapeutic side, which Jarrin's going to be focusing on today, CMS pursued what is called a splitter approach. So instead of simply doing the same thing that they did with remote physiological monitoring, which you can use the code, it's not differentiated when you're using it for diabetes or for cardiovascular disease and monitoring of your blood pressure. In the therapeutic space, CMS and Medicare and the CPT editorial panel who creates codes, one of the entities that creates codes, um, they have decided to adopt a model where your initial setup is the same regardless of your therapeutic intervention. Your professional service code and the additional 20 minutes is the same regardless of the service that you're providing. But when you talk about the device supply, that looks different. It's a different code, it has a different descriptor. And so there's one for respiratory, there's one for musculoskeletal, and there's one for cognitive behavioral that the CPT editorial panel created. But today, Jarrin's going to be talking about that code, that device code for cognitive behavioral, because it turns out CMS has created a family of codes that are called the Medicare Digital Mental Health Treatment Remote Codes that look almost identical to these codes that already exist for cognitive behavioral um, remote management. So I'm not going to steal too much of his thunder, but I wanted to make sure that you had this framework in your head because he's going to take a deep dive into this issue and it's going to help for you to have this as the context. He is going to be focusing on an Aislinn. We're going to draw people's eye to where you see the little blue box on the left that's clear and that cognitive behavioral device box. A lot of the conversation is going to focus right in that area, but not exclusively. So with that, I'd like to introduce our subject matter expert. Jarrin has been doing really foundational work in the remote management space for a very long time. He is one of the original individuals who helped develop the remote physiological monitoring codes. He's a member of the American Medical Association's Digital Medicine Payment Advisory Group, one of the foundational members, and really a moving force for the creation of modernizing the remote physiological monitoring codes, and was heavily involved in all the discussions around the remote therapeutic monitoring and management codes. So with that, I'm going to turn it over to him because he has a lot to cover. And just a reminder, we will have the webinar available for on demand afterwards. You're likely going to want to go back and listen to some of this. So with that, Jarrin, take it away.
Sylvia, next slide, please. And thanks for Citrix for having me. I'm going to go off camera. It's just a little bit easier. I typically get very distracted watching myself on camera. So welcome, everybody. We're here to talk about the 2025 Medicare Physician Fee Schedule Final Rule. The final rule was issued Friday, November 1st, 2025. Apologies for that. I'm sorry, 2024 for 2025. Apologies for that. This is the link for the rule. I'm assuming, Sylvia, are you guys going to make these slides available somehow, or at least the information available?
We sure are. Yes.
Okay, great. All right. So the final rule can be found there. It can be found online, Federal Register. I encourage everybody to go and download it. I think they still have the inspection copy up, but that's going to change soon. Today's webinar is really to discuss three topic areas of interest in digital health. One would be the area that Sylvia started talking about, the digital mental health treatment codes. Another is general care management services in rural healthcare centers and federally qualified healthcare centers. The last one being advanced primary care management services. Next slide, please. And Sylvia already went through this, but just good visual to have. Important for folks to understand that for the remote therapeutic monitoring services, there are 4 practice expense only codes. What does that mean? It means that there's no physician work involved in those codes. And that would be the codes before you, 98975, 98976, and 98977, and one more additional code that was made later, which I'm going to go over in 2 seconds. In addition to that, there are remote therapeutic monitoring treatment management services, which I will get to in a moment as well. But in this slide, you will see the 3 codes. I've got them in green because they are actually active codes. They're covered and they're paid by CMS. The 2024B, what the B stands for is that there was payment assigned to to the entire fee schedule last year. And then through an act of Congress in March that President Biden signed into law, there were changes to the amount of reimbursement that was being provisioned. So these fees that you see here, the costs reflect that. So that's why we've got the 2024B. So you'll see here the code in green, active and paid. Those are the payments. The code's 98975 for remote therapeutic monitoring, example given therapy, adherence, therapy response. Important to note, digital therapeutic intervention is new language that was inserted into this code by the American Medical Association current procedural terminology editorial panel. And then the code goes forward with initial setup, patient education on use of equipment. What does the digital therapeutic intervention mean? To me, it has not really necessarily been defined, but having been involved in some of the machinations going on in the background over this code, I would say that this is work being performed by the machine, meaning that the software is actually doing some aspect of a treatment. That would be the intervention. So this was a big change, a big addition by CPT. And this new language is new for 2025. It will appear in the 2025 code books, which just went live a couple weeks ago. 98976 is a device supply code for the support of monitoring of respiratory system, and 98977 is a device supply code for support of monitoring of musculoskeletal system each 30 days. Next slide, please. And 98978 was the last code that was added to this family. This code went into effect in 2023. This code is not covered or paid. It was assigned a $0 valuation a couple of years ago when it went live, and it was sent to contractor pricing, which means that the 12 Medicare administrative contractors are free to either pay the code, adopt the code, or not adopt the code, or reject the code. It's my understanding that there have been some invoices that were submitted by providers that were actually incurring the expense as described in 98978, which is for the device, the supply of the device to support monitoring of cognitive behavioral therapy each 30 days. This code, even though it is an active code according to the CPT, in an active code according to CMS, because it was assigned to contractor pricing, is not paid, and we won't know when it gets paid until a contractor decides to pay it. If there's consensus among many contractors that the code deserves to be paid as a national coverage issue, then CMS can issue a national coverage determination through the fee schedule and adopt a payment for this code. That has not happened yet. So this code remains unpaid. Next slide, please. And here we get to the treatment management services. Now, these codes have provider work involved, as well as practice expense and provider liability. So these codes have all of the relative value units, and that's why I've got these also in green. These are active. They are covered and paid by CMS. First code being 98980 for remote therapeutic monitoring treatment management services, time in a calendar month requiring at least one interactive communication. 98980 is the base code that serves for the first 20 minutes. 98981 is for each additional 20 minutes. In 2025, what CPT has done is that they condensed the language for 98981, and they really just have what's before you each additional 20 minutes. You have to list it separately in addition to the code for primary procedure, but that's the way that these two codes look. So these codes are related to the remote therapeutic monitoring codes, which I showed prior, in the sense that these are the work that is involved in monitoring the data that's coming from the medical devices as described in those other codes. The reason that we're talking about all of this is because what CMS has done and finalized for this new rule going into 2025 does in a way impact or cause some aspect of confusion, and I'm going to talk about that. Next slide, please. Here we go. So these are the digital mental health treatment codes that CMS has just finalized. These are the final numbers. They had a very different number when they were being proposed. These are CMS HCPCS codes, G codes for a provider service. The first code is G0552. You'll notice that it's in red. It's in red because even though this code is now active, it was also assigned a $0 valuation, and beginning in January 1, 2025, it will not have any assigned payment. That also will be going to the contractors. And much like what happened with 98978, it will be at the contractor's discretion as to whether or not they're going to pay these codes. We don't know that. Typically, what happens is that the contractor, upon receiving invoices for these types of codes, if there is broad utilization, they will embark upon a gap-filled methodology process to try to come up with a payment valuation for a particular service or supply of equipment or procedure or whatever once it has been assigned to contractor pricing. So we really don't know whether or not these contractors are going to embark on that for G0552. I believe that the hope is that they would. Now, this code is for the supply of digital mental health treatment devices and the initial education and onboarding of such a device per course of treatment that augments a behavioral therapy plan. As you'll see in the descriptor, it's quite similar to the code that exists, 98978, although I would say that this code condenses two separate concepts that CPT split. One concept being the setup and education and onboarding, and then the other concept, the actual supply of the device. This code condenses both, and it has it just in one code. Now, the second part of this new code family that CMS has created are these codes G0553 and G0554. These are identical to each other. The first code being, and they're both work codes. These are not practice expense only. These actually have a work component. So that's the time, the intensity of the provider who is furnishing any kind of what I'm going to call treatment management. So you will see here, first code G0553, this code is active and is being paid. It was assigned the same valuation as the existing remote therapeutic monitoring treatment management service codes, which are 98980, which I presented in the slide prior. And then, of course, G0554 also covered and paid for each additional 20 minutes, which corresponds to the other code 98981. Again, very similar in what they sound like, as you'll see in the descriptor. First 20 minutes, treatment management services, therapeutic use of the digital mental health treatment that augments a behavioral therapy plan, physician or qualified healthcare professional time reviewing information related to the use of the DMHT device, including patient observations, patient-specific inputs in the calendar month, and reporting at least one interactive communication with the patient caregiver during the calendar month. Interestingly enough, this code does factor several things which may not be present in the 98980 and 98981 codes in the descriptor. But if you were to see the guidelines that CPT put forward and the intra-service work, you will note that these codes are identical. And they're so identical that CMS decided to crosswalk them. That's a fancy term for saying we are going to adopt them because they are analogous and very similar to an existing service that is actually covered and paid. Therefore, they will have the same relative value units. And that's why you see both of these codes being paid, and they're paid at the exact same value of which 98980 has assigned, as well as 98981. So again, one would ask, why were these codes created? Next slide. Now, there are a variety of different things that are being positioned for these codes. I'm not going to get into all of those nuances. A lot of them do track, generally with remote therapeutic monitoring writ large. However, some things that are very specific to these codes that have been finalized by CMS is here, for example, what types of devices the limitations are on those devices. Number one, they have to be cleared under Section 510K of the Food, Drug, and Cosmetic Act. No surprise there. Interesting that they use the language of cleared, because cleared typically means a Class 2 device, doesn't really say anything for a Class 1 device or even a Class 3 device, which there aren't many of those, if any. However, the language that CPT has always adopted behind remote monitoring is really a device as defined by FDA, because that way it just includes all devices, whether Class 1, Class 2, or Class 3. As we see the advancement of technology, many devices are coming in now at Class 1 or Class 2. Again, not many under Class 3. However, this was an interesting choice of language. They went further and said including de novo, and de novo are products that are being presented to FDA that don't have a classification for which the FDA would create a classification. That could be Class 1, Class 2, Class 3. So interesting that they say it this way. Now, from there, they go on and they actually specify very specifically which product panel really satisfies the device types that can be used for these codes. And as you can see here, the regulation number is 882.5801, which only includes the following product codes: QVO, which is typically products that are for computerized behavioral therapy devices for insomnia; product code PWE, computerized behavioral therapy devices for substance use disorders; and product code SAP, computerized behavioral therapy devices for depressive disorders. This is very interesting because in the marketplace, there are a variety of other devices that fall under other FDA classifications as panels, as I like to call them. For example, 21 CFR 8825803, product code QFT, that would be for ADHD, or 876.596 QMY, that's for irritable bowel syndrome, and 886.5500, which is a digital therapeutic for amblyopia. Those are not in this list. Therefore, those are disqualified. Anyone that's using any type of digital therapeutic device, for a QFT or a QMY or the amblyopia product would not be able to bill these codes. That's a very specific stipulation on the part of CMS. Interesting to see how that will grow in the future. Next slide, please. Or how they'll deal with it. Now, one thing that I do want to clarify, CMS goes through great pains in the proposed rule to basically not necessarily proactively stipulate, but they infer and they refer to these codes being really for the purpose of interventions. Remember that the existing remote therapeutic monitoring codes now include the word intervention in the descriptors of at least the base code 98975. So it's very interesting that these codes, the ones that have been finalized by CMS, do not even have the word intervention. So again, you have to wonder, how distinguishable G0552 and obviously 553 and 554 are from the existing CPT codes. I would argue that they're really indistinguishable. CPT code 98975 was modified by CPT to include the word intervention. That actually goes live January 1st, 2025. So that adds a level of uncertainty between these codes and the existing codes. G0552 includes setup and education, supply of equipment. CPT, differentiates that between two different codes, 98975 and 98978. G0552 has no payment indefinitely, as far as I'm concerned, starting January 1st, 2025. Same exact situation for CPT 98978, which has been sitting at contractor pricing for 2 years. 98975, the setup and education code, that is a category 1 code that actually is active. It is covered and it is presently paid. So that is something that can be used by providers presently. G0553 and G0554 are identical. They're crosswalked to 98980 and 81. Commercial payers typically do not utilize HCPCS-G codes, but they do utilize CPT codes. And very importantly, CMS is really, that's their code set, right? G codes. So they do recognize and utilize and pay G codes. And they both, really, CMS as well as private payers recognize, utilize, and pay CPT codes. So, what I would argue is if there's so much uncertainty behind the G codes and I am able to, get paid, I being a hypothetical provider, am able to get paid for setup and education, and at least to work via the existing CPT codes, I think that that's a better option, quite frankly, until these codes are more more information comes out about them or more clarified by CMS. Next slide, please. I see Sylvia coming off camera, so I want to make sure that I've got anything that she wants to refer to. Sylvia?
Yeah, I just want to do a time check because we have
about 6 minutes.
Yes, and
Yeah.
we have some folks that have questions about the FQHC, RHC policy change. So I want to make sure we get to that.
Yeah, which is where we're going. So, new topic. This also something that was finalized in the present 2025 fee schedule: payment policy for general care management services in rural healthcare centers and federally qualified healthcare centers. CMS proposed and now finalized that RHCs and FQHCs may bill individual codes that make up the bulk of the general care management service codes, or code rather, that they had created, G0511, which really encapsulated all of the general care management services. That includes collection and interpretation of data, principal care management, chronic care management, remote physiologic monitoring, the self-measured blood pressure readings, behavioral health care management services, complex chronic care management, remote therapeutic monitoring, principal illness navigation services, chronic pain management, behavioral health care management, and community health integration. Those were all encompassing or all made up G055, what G0511 rather. What they did was they included all those services. They gave it a blended rate by averaging all of those services together, which was unfair for higher valued codes and more really very generous for lower valued codes. That is not going to happen any longer. G0511 will no longer be payable when billed by RHCs and FQHCs. CMS is going to allow a 6-month period so that RHCs and FQHCs can come into compliance with this new rule. So until January 1st, 2025, that will be in effect to update billing mechanisms. Thereafter, G0511 will no longer be payable at all. Next slide. Another final clarification and holding that CMS came out with is the creation of the Advanced Primary Care Management Services, APCMs. These aim to improve primary care management systems, health outcomes, help lower mortality, and reduce disparities. CMS finalized a proposal to establish coding and payment for APCM services. There are 3 new HCPCS G codes that have been created, and they vary according to intensity level. Level 1, level 2, level 3, you'll see here G0556 for a person with 1 chronic condition, G0557 for people with 2 or more chronic conditions, and G0558, 2 or more chronic conditions and the status as a qualified Medicare beneficiary. APCM services incorporate all of the elements of existing care management and communication technology-based services into a bundled service. And very important, there is no time-based threshold included in these service elements. It's really intended to reduce administrative burdens associated with current coding and billing. Next slide. And you'll see here that the code requirements for APCMs is very much, a blend of, communication-based technologies and others. You'll see consent, initiating visit, 24/7 access, continuity of care, comprehensive care management, patient-centered comprehensive care plan, management of care transitions, care coordination, enhanced communication, population-level management, performance measures, all are now incorporated into APCMs. For MIPS-eligible clinicians, a performance management service element can be satisfied by reporting the value in primary care MIPS pathway starting in 2026 based on your 2025 performance year. That concludes my slides. Happy to now answer questions as they come in.
Yeah, there were a ton of questions. We fielded some as we went. The first one I just want to make clear, you covered, and Paola asked what kind of devices are covered for RTM, and you covered that question with regard to the type of FDA medical devices that would cover. Rami asked, did CMS expand RTM use cases? And the answer is essentially no,
Really?
right?
Yeah, not really. No, no. And I say that also from the perspective of, this is a CMS created proposal. It's a HCPCS code. It really has nothing to do with CPT codes. CPT codes are owned, curated, managed by the American Medical Association Current Procedural Terminology Editorial Panel. So very different code set, different set of stipulations, requirements, guidelines, etc. So that by them doing this, they're not really interfering with CPT. However, there is a code clash, as I have presented. That's problematic because that causes provider uncertainty. Which code should I use? Which one's more appropriate than the other, et cetera, et cetera. So I would answer no.
And then Ben Gallen on the FQHC RHC question, they asked about coinsurance, and he asked specifically about the coinsurance for the old code that's about to be retired, the G0552. But, really looking forward, the question is, are there co-pays for the RPM services prospectively, but based on the new codes. Or they're not really new codes, but the
Yeah,
CPT
they're not new codes,
codes
right?
and this
Exactly.
the Hicks
Yeah,
picks.
coinsurance is still there. Coinsurance has not gone away. I believe that that would take an act of Congress to get rid of coinsurance. It's something that has been regulated for years by CMS. That's, I like to say it's skin in the game, that they like to show that the beneficiary that's benefiting from this has some kind of, payment assigned to the services that they're receiving. Next
And then
slide,
one
or
last
not next slide.
question.
Sorry, next question. Next
Then
slide.
one last, and then
Sorry.
one last question, then we're going to wrap up and thank everyone for coming. Ben asked, like RTM, can the 20 minutes be by auxiliary staff, or does it have to be specifically done by the QHP?
I believe that these codes are going to be allowed to be general supervision as well. Don't quote me on that, but I'm pretty sure that that's what they had alluded to in the final rule as well as in the proposed rule. So that part is probably going to be very similar. But again, I'm not sure that I would recommend, those out there looking to these codes. I think that you're better off using the existing codes until this gets better clarified. At least that's my
Fantastic.
perspective. And that's my
So,
opinion, not
yeah.
that of Citric, and not that of the industry, not that of anybody else.
Got it. Yeah. So, Jarrin, this has been phenomenal. You're great. We covered a lot of ground. We want to encourage you to join us for part two, which will be November 21st, where we'll cover telehealth. And we are going to make this available on our YouTube channel and on our website. And we'll also have some handy leave behind documents that you can download. And, we appreciate the speed with which Jarrin got us the information, and we look forward to further collaborations. Thank you all for joining us.
Thanks for having me.